I'm a pain management specialist, a physician whose entire practice is built around patients whose back pain has not responded to the standard approaches. And after 18 years working almost exclusively with adults over 60, I want to talk to you today about something that sounds almost too simple to be true, and yet has more clinical support behind it than most of the treatments people spend thousands of dollars pursuing. Back pain is the single most common reason adults over 60 report losing functional independence. Not a fracture, not a cardiac condition. Back pain, the morning ritual of sitting at the edge of the bed, waiting to find out how bad today is going to be. The decision to skip the outdoor birthday party because you can't be sure there will be a chair when you need one. I see this in my clinic almost every single week. Patients who have been cycling through stretches and heating pads and anti inflammatories and brief improvements for years without ever getting ahead of the problem. Today, I want to explain exactly why that cycle keeps happening. And then I want to show you one specific 60-second movement that targets the underlying mechanism directly, not the symptom. The mechanism, if you are over 60 and your back has been bothering you, whether it's every morning or just unpredictably, stay with me. What I'm about to explain is what a standard 15-minute primary care appointment almost never has time to cover. By the time this video ends, you'll understand why so many people cycle through generic advice without arriving at a real answer. And understanding the mechanism is the first real step toward interrupting it. I want to speak to you directly for a moment. If you have been managing back pain for more than a year and your doctor told you to stretch more, keep moving, and take something for the pain, you are not alone. Somewhere between 60 and 80% of the patients I see over 60 fall into exactly this category. People who received general guidance but never had the actual biology explained to them. That is not a failure of your doctor. It is a failure of the 15-minute visit. What I am giving you today is the conversation you should have had to understand what is happening in a back that has been painful long enough to become chronic, longer than 3 months, let's say. You need to understand a process that most people never hear explained. When your back hurts repeatedly, the nervous system makes a change that feels protective in the short term and becomes deeply counterproductive over time. It suppresses the muscles closest to the area of pain. Not because those muscles are torn or damaged, because the brain, interpreting persistent pain signals, learns to treat the lower back as a zone of active threat, and it reduces motor output to that zone. The muscles it suppresses first are not the ones you can feel and stretch. They are the deep stabilizing muscles, the ones that sit directly against your lumbar vertebrae, invisible from the outside, that are supposed to fire automatically before any movement you make, like a pre-tensioning system that locks your spinal segments into stable alignment before your limbs ever begin to move. When those muscles go offline, the larger superficial muscles of the back, and designed for movement and power, not for sustained postural support, try to compensate. They fatigue quickly. They go into spasm. Pain worsens. The brain interprets more pain and suppresses the stabilizers further. Pain causes inhibition. Inhibition causes instability. Instability causes more pain. A heating pad temporarily interrupts this cycle. It does not stop it. Research published in the Journal of Pain Research and sustained across decades of clinical investigation, including foundational work at the University of Queensland in lumbar motor control, has documented this inhibition pattern consistently. The finding that matters most is not simply that inhibition occurs, it is that the inhibition does not resolve automatically when the original source of pain improves. The motor pattern stays disrupted. The nervous system does not return spontaneously to its pre pain coordination. It has to be specifically re engaged. There is a second layer compounding this, what pain researchers call central sensitization. When pain persists beyond a threshold, typically in the range of 3 to 6 months of recurrence, the nervous system recalibrates its sensitivity. The alarm threshold drops. Pain begins appearing with less and less mechanical justification, not because the structural problem worsened, but because the system interpreting the signals has become hypersensitive. The American Academy of Pain Medicine has published extensively on this in the aging adult population, noting that it is systematically underrecognized in routine clinical settings. Anti-inflammatories provide partial relief because they address peripheral tissue inflammation, not the sensitized central processing. That is the biological explanation for why so many patients feel better for a few days and then find themselves exactly where they started. The error I see most consistently in patients trying to manage this on their own is treating back pain as a flexibility problem. They add stretching, they walk more. But mobility without the stabilizing system re-engaged is counterproductive. A mobile spine without muscular pretensioning shifts during movement in ways it should not, creating new points of load and new pain signals. You end up more limber and no more stable. And an unstable back in motion is still a painful back. What the body needs, specifically and precisely, is a signal to the nervous system that the deep stabilizing muscles are safe to reactivate. That signal can be delivered in 60 seconds. Find a firm surface and lie on your back. A yoga mat on a hard floor works well. A firm rug is fine. Your mattress is too soft. It distorts the feedback you need. Bend both knees so your feet are flat, hip width apart. Let your arms rest at your sides. Notice your lower back. There is a natural small curve, a gentle gap between your lumbar spine and the floor. Do not press it flat by tilting your pelvis. Do not exaggerate it by arching. Let it rest in its natural position. This neutral alignment is where the deep stabilizers can engage most efficiently, and learning to find it consistently is itself a form of motor repatterning. Place your fingertips on your lower abdomen just inside your hip bones. You are locating the territory of the transversus abdominis, the deepest layer of the abdominal wall, which wraps horizontally around the lumbar spine like a natural internal corset. To find it, imagine gently drawing the lower abdominal wall inward and slightly upward, not sucking the whole belly in, not bracing hard, not holding your breath. A 10% contraction. Quiet, specific. Think of it as a gentle narrowing that you can barely feel from the outside. Your rib cage should not move. Your pelvis should not tilt. Your breath should continue normally throughout. If you have to hold your breath to maintain the contraction, you are working too hard. Go smaller. Hold that gentle contraction for 10 seconds while breathing normally. Release for 5 seconds. Repeat 6 times. That is your 60 seconds. What you are doing is not building strength in the conventional sense. You are restoring a neural firing pattern, sending a specific low load signal to the motor cortex that the transversus abdominis is available, safe, and expected to participate. Each correct repetition reinforces that signal. Precision at low load is the mechanism here. High intensity core work recruits superficial muscles and masks the deficit rather than addressing it. A correct, specific signal repeated consistently over time reorganizes the motor map. That is what this exercise accomplishes, and it is why nothing about it is interchangeable with general core training. Timing is as important as technique. The optimal window is first thing in the morning before you stand up. Now, before you swing your legs over the side of the bed, before weight goes through the spine. The overnight rest has slightly reduced compressive loading on the lumbar discs. The nervous system is in a kind of reset. This is when the signal you are sending has the clearest path to effect, and when the stabilizers, once activated, will be primed to support you through the loading that immediately follows. 6 repetitions on your bed if the floor is not accessible on the firmest part you can find near the edge. The second optimal window is immediately before any extended sitting, before a meal, before a long drive, before settling in to watch television. A brief pre-activation tells the motor system that the stabilizers are engaged. The surface muscles do not need to brace in anticipation. That preemptive activation, done consistently before loading, is one of the most underutilized clinical interventions I know of for chronic low back pain. If some of this is new to you and you want to share it with someone who also deals with back pain, a spouse, a friend, an adult child going through the same thing, please hit the like button before we continue. This content reaches people when someone who found it useful passes it along. And if you are not yet subscribed, now is a good moment. This is the kind of mechanism-focused clinical information this channel covers consistently. The most common technical error when first attempting this exercise is recruiting the wrong muscle layer. The rectus abdominis, the superficial vertical muscle that contracts during a crunch, will try to take over if you go too hard. You will know the wrong muscle is engaged if your rib cage lifts, your pelvis tilts backward, or the effort feels like you are bracing your whole midsection. If any of that happens, reduce the effort by half, then reduce it by half again. The transversus contraction is subtle enough that an observer could not see it from across the room. If something is visibly happening in your abdomen, you are probably one layer too superficial. For patients in an active flare, back pain that is acutely worse than your baseline today, reduce the contraction to 5%. The goal during a flare is not to push through. It is to maintain the neurological connection with the stabilizing system so the inhibition pattern does not deepen further while you wait for the episode to calm. A minimal Pain-free activation on a bad day is more biologically beneficial than complete rest. Complete rest is the one intervention that consistently worsens the long-term pattern. After 2 consistent weeks of the basic version practiced twice daily, add a simple progression. From the same starting position, with the gentle contraction maintained, slowly slide one heel along the floor until the leg is nearly straight. Hold 3 seconds. Slide it back. Alternate sides, 6 repetitions each. The contraction must remain stable throughout. No shift in the pelvis, no increase in lumbar tension. If either happens, the stabilizing system is not ready for this load yet. Return to the basic version for another week. Progression here is governed by control, not by elapsed time. For most of my career, when a patient needed what I have just described, structured progressive stabilization work, I referred them to a physical therapist. When that was possible, it worked. But I kept encountering a reality that is more common than clinicians like to acknowledge. A substantial portion of my patients over 60 could not access consistent PT. Insurance with a 6 session annual cap, when the research supports 16 to 24 sessions for meaningful motor repatterning. Clinic locations 45 minutes away requiring a driver. Scheduling that assumed a flexible weekday calendar. I kept giving these patients the same instructions and watching them return 3 months later with no real change. Not because the instructions were wrong, but because information without daily structure is insufficient for sustained behavior change in this population. I held that position, refer to PT, give written guidance, except that some patients simply would not follow through, for longer than I should have. What shifted my thinking was encountering a structured digital program designed specifically around this gap. Organized daily stabilization and mobility work for adults over 60, formatted for home use without equipment and without a supervision requirement. My skepticism about this category was long standing. I assumed that without a trained observer watching movement quality, patients would reinforce compensatory patterns rather than correct ones. What changed my assessment was the design. The program includes a morning routine built specifically to reactivate stabilizing function before the spine takes on the load of the day, which maps directly onto the morning timing rationale I described. It also includes a 1 minute daily tracker for pain and range of motion, a simple log that patients fill in each day, tracking what was done and what preceded any worsening. In 3 weeks, that tracker generates a visible pattern. Patients see what correlated with improvement. They see what the days they skipped cost them. That data changes adherence in a way that verbal instruction does not produce. In the patients I have directed toward this program, specifically those between 63 and 72 years old, with chronic low back complaints at a mild to moderate level and no acute structural emergency, I have seen consistent improvement in functional mobility within 2 to 4 weeks of regular use. Not in every patient, but consistently enough, repeated enough times that it has stayed in my clinical recommendations for several years. The patients who respond most reliably tend to be those for whom this was their first experience of organized daily movement with a clear progression logic behind it, not patients who had already been through multiple rounds of formal PT. This is an educational and structural program. It organizes movement principles into a format a person can follow independently, with a progression calibrated for the adult over 60 who has not been in a rehabilitation setting. It is not a treatment for any diagnosed condition. It is not a substitute for professional evaluation. For someone with an acute structural emergency, active nerve compression, a recent vertebral fracture, this is not the starting point. But for the patient with years of low grade recurring back pain, no acute imaging finding, and a life that has progressively organized itself around limiting movement, this fills a specific and real gap. The link is in the description if you would like to look at the structure of the program at your own pace. The lumbar spine does not exist in isolation. When the deep stabilizing system stops functioning correctly, compensations ripple outward. The hips begin rotating differently to protect an unsupported lumbar segment. The mid-back stiffens as it absorbs loads meant to be shared across the lumbar region. The knees track off axis because the hip mechanics have changed upstream. I regularly see patients in their early 70s presenting with hip or knee complaints that, on careful history, began approximately 2 years after a period of worsening low back pain. The back's instability became the whole body's structural problem progressively over time. The behavioral consequence worries me as much as the mechanical one. There is a pattern clinicians who work with this population recognize immediately. the progressive constriction of life around the fear of triggering pain. No longer walking the uneven path at the park, no longer reaching into low cabinets, declining travel because the seat situation on a plane is unpredictable. Each decision is rational in isolation. Taken together, they represent a withdrawal from the very activities that maintain stabilizing muscle function, and each withdrawal makes the next episode more likely and more severe. Research is consistent. Adults over 60 who maintain daily spinal loading and stabilization work demonstrate significantly better functional independence measures at 75 and 80. Independence defined specifically: rising from a low chair without using the armrest, stepping over a threshold without hesitation, carrying a bag without bracing. After 18 years in practice, the difference between a patient of 72 who has kept moving and one who stopped at 67 is visible in the first 90 seconds of a clinic encounter, in the way they come through the door, in the way they lower themselves into the chair, in the way their body handles small transitions. Most people don't notice until those transitions become difficult. I have never once looked at a patient who maintained consistent daily movement and thought they moved too much. Here is the summary of what we covered today. The chronic low back pain cycle that does not respond to generic stretching is, in the majority of cases, driven by a motor inhibition pattern. The deep stabilizers go offline in response to persistent pain and do not return without a specific signal. The 60-second transversus abdominis activation delivers that signal. 10% contraction, 10 seconds on, 5 seconds rest, 6 repetitions before rising in the morning and before extended sitting. No equipment. 60 seconds twice daily with technique precision is the only non-negotiable. Tell me in the comments what activity or position most reliably triggers your back pain. Not just the time of day, but the actual thing you are doing. Sitting at the dinner table? Getting out of the car? Making the bed when you bend forward? That specific answer tells a precise story about where in the movement pattern the stabilizing system is failing most consistently, and it shapes what I cover in future videos. The stabilizing capacity we discussed today remains trainable at 65, at 70, at 77, but the rate of motor repatterning slows with each year of continued inhibition and protective inactivity. Not a cliff, a gradient, measurable and real. The window for the most responsive retraining is now, not in 6 months, because every year of disuse deposits another layer of inhibitory adaptation that takes longer to reverse. The structured program I mentioned is in the description below. Take your time reviewing how it is organized, the daily progression, the morning sequence, the 1-minute tracker, and decide whether the structure fits how you actually live. There is no artificial deadline here. What I would ask is that you not treat this as something to return to later, because the biology does not wait on convenience. And what I am sharing here is education, not a personal diagnosis. If you have a specific condition currently under treatment, a structural diagnosis, a medication protocol, an ongoing referral, please talk to the physician who knows your full history before changing anything in your routine. That is not a disclaimer I am reading reluctantly. It is the right clinical sequence. Understand the mechanism, assess it with someone who knows your full picture, then act. The link is in the description and in the first pinned comment. 60 seconds in the morning. The patients who have committed to that consistently describe something that takes a while to name accurately, a back that begins to trust itself again. In 18 years, I have not found a more precise way to describe what happens when the stabilizing system comes back online.